Hi, Cadence.
Hi.
I had to, I was just finishing up another little meeting. So I just sent out a little announcement saying that we were going to start at 2:10. So
Oh, okay.
can you just hang on until 2:10?
Yep.
Okay. I'm just going to hit pause for the recording here. And then I'll see you in a few minutes. Did you have any questions about anything?
No, not really.
Okay. All right. Um, then then I'll see you in a few minutes.
Okay.
All right. Well, hello. Now it's a party because we got Raina and Cadence here. How are you, Raina?
I'm good.
Good. Good to have you.
This I sent this to Miss Bonnie, probably not appropriate, but I'm working on my safety manual today.
Uh-huh.
And oh, I don't have the video. Hold on. And I found this. Don't repeat it. Those are truly the steps I would take.
I think that's perfectly appropriate.
Right? I was like, safety manual done.
That's it.
Right there. All right, I'm gonna let you teach class now.
Okay. Well, hello. Okay, so you don't have to. I'll have copies on Wednesday, but if you go and you open in Canvas, I'll just show you real quick. I'll try to show you. If you go into can you guys see my screen? Maybe just give me a little thumbs up or something.
Yep.
Okay.
Yes.
If you go over into the modules, I made some little study notes. Let me show you here. So under lecture and PowerPoints, there's this little lecture link here. So if you click on these class notes, they're notes to follow along, but you can just download it. Are you seeing a Word document opening on my screen?
No, it just says lecture link notes.
Okay, let me show you the now do you see it?
Yeah.
Yes.
Right. So hey Vanessa, so if you want
Hello.
if you want to, you can you could download it, and I'm sorry I didn't get it up sooner. But it's not super important. Today we're going to mostly be, I can provide you most of what you need, but I'd be curious if you are able to, because what's going to happen is the three of you are going to work to solve a couple of cases down here. Mm-hmm. And so if you're able to open it, it'd be good, but we'll come to that in a moment. Okay. I'll come back to that. But while I'm blathering on here, if you can try to, if you're able to open it, let me know, and then I'll ask you again in a couple of minutes. Okay, let me go. Let me see what I want to do here.
Open what? Sorry, my computer partially froze for like 10 seconds. I missed some of what you said.
Oh, Cadence, go under in Canvas. Just open up Canvas. Well, you know what I'm going to do? I'm just going to email the three of you right now. How's that?
That'll work.
Let's just do that.
I'll shoot it out from there.
Okay. Let's just do that. So hold on. I really, really appreciate you coming. So here are the notes.
Listening to a recording.
Yes, me too. Okay. All right, I just emailed you the notes. So you just you don't even have to mess around looking around on the module, okay? So while I'm blathering on, that you can open that up. And let me get this ready. And I just ate a bunch of peanut butter, so I really want to like run my finger around my mouth to get this peanut butter. So I'll try not to though, because that's gross. Okay. All right, you all see this PowerPoint here?
Yep.
Okay, very good.
Yes.
Okay. I think you'll enjoy this. I think you'll find this kind of interesting. Right. So, you've all done anesthesia, at least twice. And I'm going to sip a little tea while we're talking here. And I think you've all encountered a couple of strange things, have probably happened. Can you all remind me? Did you have like Vanessa had like the perfect anesthesia? All right, nothing went wrong. All right.
Only this time around.
Okay, well, so can you all just remind me, what are some things you've either seen happen here or happened to you while you were anesthetist, or what are just some things you've seen happen?
Well,
My
we had that
patient
puppy
last
whose
week having
respiratory
that
rate went
complete
down
up
to
and down heart
4.
rate.
Oh, wait. Oh, sorry. Go ahead, Raina. Maybe just one at a time. Raina, you had the one.
We had that puppy whose respiratory rate went down to 4 breaths a minute.
Okay, so we had a really slow respiratory rate, hypoventilation. Okay, and of course we had that little cat with that strange little. We had a cat. Raina was recovering a cat with a kind of a. It sounded kind of like a sinus arrhythmia, but not quite. It was a little strange. The cat.
It was bump, 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 pause. Bump, 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 pause.
Yeah, it was a little weird, but he was fine. I don't really know what was going on. Sometimes we don't. If it had been more serious, I would have given him, lidocaine or there's a variety of things I could have done. But sometimes you just watch and wait, and the problem will fix itself. What else have we seen? Have you seen?
There was my dog last week where her heart rate kept going, bouncing between 40 and 60 the
Oh,
entire
okay,
time
okay.
under anesthesia.
That's right. So yeah, okay. So bradycardia. Yeah, that's common. What about you, Vanessa?
So yesterday, actually, at my internship, there was a cat under anesthesia, and he started abdominal breathing.
Oh,
And turns
weird.
out it was because they didn't put him on a non-rebreather. They were having him on a rebreathing system.
Oh.
So yeah, I thought that was like, oh wow, I never thought I would see the abdominal, but there was that.
No, I never have. No, but yeah, it's interesting. I mean, this is one of the fun things when you guys, 10 years from now, when you run into each other at conferences, you get to share all sorts of horror stories. It's wonderful.
Yeah.
It actually is. I shouldn't say horror stories. All right, well, cool. We'll keep, certainly as you think of other things or you want to speak up, we'll come back to that. But we're going to look at 4 of these problems here in part 1. We'll look at a patient who keeps waking up, or a patient who is too light, a patient who's too deep, a patient who's not breathing, and a patient who appears to have a low blood pressure. So we're going to start by also just talking about there's something the book mentions in chapter 26 called the governor vessel 26, and I thought I'll just kind of I'll describe to you what that is, and then the book doesn't mention this. It's an intervention called the vagal maneuver, but it's also kind of a cool thing to know. So we'll talk about that. And then we're going to mostly talk about some of the causes and responses to some of the common anesthetic problems. Okay. So, as we've said, most of the time, if we do everything right, most procedures are very uneventful. But that's also kind of the danger, right? Because you start to get a false sense of security. And something that someone said to me once, and I've seen it at work, I've seen it here. When do you think most, we'll say most students, but it's really most people, when do they make a mistake? Is it the first few times they do something? Is it like a month or two later? What do you think? When do most mistakes get made?
When they feel the most comfortable, when they've done it a lot of times.
Exactly. It happens every year, and I'm not criticizing other classes, but it's in the second semester, it's in spring semester that we see people forgetting to do things that they knew in the fall. And so just be aware. It's true in anything you do. Just be aware. Don't let yourself get overconfident. So what are some complications that? Well, you guys gave some examples. There are, the book talks about things like it has a nice little description of what to do if a patient regurgitates, what to do when if the carbon dioxide absorbent is saturated. And so we're not going to talk about everything in the book. But certainly just by looking at these images here, they may strike some, you may remember other things, right? You can certainly have problems with the equipment. A tube could become obstructed. Again, there's that CO2 absorber getting saturated. Hypothermia. This is actually a full, but certainly patients can get cold. They can develop bradycardia, like Cadence's case. So there's a great many things that can go wrong. And so what are some of the causes? So you may recall at the start of chapter 31, we learned about the American Society of Anesthesia. They have this numbering system. So 1 is for a totally healthy patient, nothing wrong. 2 would be, well, some little thing is wrong, all the way to level 4, which is they have like a serious life-threatening injury and or illness. And 5 is they're gonna die without surgery, and they might even die with surgery. So obviously we and occasionally we see them all. You'll see you will be the anesthetist for plenty of stage of ASA 3 and 4 patients. And if you do emergency medicine, well, even regular medicine, you're going to see some 5s. But other than illness, it's not just illness. What are some other things that could influence these? Let me just back up. Yeah, so it's not just patients that have some illness. What else could influence this ASA? It's not really mentioned in the book, but just maybe use your own kind of.
Having adverse reaction to like the anesthetics.
Well, this is before we've even done anything. So here's an example: a neonatal patient, right?
I was going to say age.
Yeah, age. So a really, really old or really, really young patient, they could be perfectly healthy, but it can affect, it can affect this. A pregnant patient, things like that. Certain breeds, like we're not really talking about it, but greyhounds, the sight hounds, they tend to be more sensitive. You learned about the collies, like and they lack that P glycoprotein, you know, so certain drugs, you might overdose them, just things like that. You know, it's just good to be aware that certain breeds, certain ages, like Raina said, that can also maybe, it probably wouldn't, it just maybe makes them into a class 2, but still it does increase the risk of a complication. And then, like Raina said, there can be adverse drug reactions. Um, again, what are some of the common side effects we've learned about with these drugs? You know, let's take ACE. Yeah, ACE, propofol, the alpha 2 agonists. You know, what are some common opioids? What are some common side effects we see?
ACE can cause hypotension.
Yes, ACE can cause hypotension. What can opioids and propofol cause?
Is it respiratory depression?
Yeah, and then that leaves what can the alpha 2 agonists do? Like dexmedetomidine. I lose you all. That one is going to cause bradycardia. I'm always afraid that you're all gone, and I need to make sure you're not gone. Wait, you're
Yeah, I
still.
was trying to go through every side effect I knew in my head.
Well, those are very helpful ones to remember. And there's some uncommon side effects too, but the you know the I mean, for example, you know, ketamine can cause, you know, I guess potentially ketamine could cause an arrhythmia, but that's pretty uncommon. And then, you know, what are some things that could go wrong with your machine? You know, I mentioned the carbon dioxide, excuse me, the carbon dioxide granules. Vanessa said, you know, if you've got a rebreathing system when you should have a non-rebreathing system, you know, maybe malfunction doesn't just mean something's broken. It can just mean something's not set up correctly. What are some other things that could be equipment malfunctions?
Forgetting to check the ISO.
Well, that's true. Yeah, yeah, absolutely. Yeah, not checking your ISO levels. Um, what's something people forget to check on their ET tube?
The cuff?
Yeah, next, you know, it's really easy to forget to, you know, you want to choose 3 tubes, you know, the size you want, and then get a size above and a size below, and you want to check the cuffs on all 3. You got to leak test the machine. You know, make sure you have a reservoir bag on. I mean, it gets very easy to forget things. So that's why I always work off a checklist. Certainly, giving too much of a drug could cause problems. Surgery, you know, like I'm in there, I could cut a big blood vessel, and now the patient's, you know, bleeding. And then of course there's all the things that can you know, involving just human error. So there's going to be I guarantee it won't be long, but new drugs will arrive. You'll be at your clinic in these next 5, 6, 7 years, some brand new drug, and you'll have never used it before. So you can, it's good to get training in it. The you know, by the time you graduate from this program, you will have adequate training in all the equipment, not asking important questions. You know, has this, it's like, I had a patient that, if I'm doing anesthesia on a patient, I like to get a hold of records, previous anesthesia records, for example. It's amazing what you can learn or what you might miss if you don't look at the history. Doing a proper physical exam, you know, making sure they're not anemic, they don't have a arrhythmia, they don't have some reason, they're not dehydrated, whatever. Drug calculation errors, and just being tired and stressed, all of those things. But luckily the team of the veterinarian and the RVT, we can prevent most problems. And in the rare times that not rare, but the times we do encounter problems, we can solve it. Okay. So these two little interventions I want to told you about. One is if you look at yourself in the mirror, you've got this little kind of valley right below your nose. And there's some sort of a nerve that must travel through there. I don't know the name of the nerve, but in the world of acupuncture, this is called GV26, and it stands for governing vessel 26. And so let's just talk about that. This spot, and you've probably heard of acupuncture. People will get acupuncture for a variety of reasons. Most commonly, it seems like it's for pain, arthritis pain, neck pain, back pain, neuropathic pain, but it has other applications. So, and what happens here is in your patient, you can push, or you can even take. I'm not gonna do it, but you can even take. This would be way too big of a needle. I believe you would take more like a 22 or 25 gauge needle. I don't want to poke myself, but you would just stick it right here, and you would just push gently until you hit bone. And then you would just, kind of gently turn the needle. What this can do is it can actually do several things. It can stimulate a patient to take a breath. You can read it for yourself. It can also stimulate the heart. It'll stimulate the heart to beat faster and with more strength. So you can also use it to increase heart rate, increase blood pressure. Stroke volume, that's the volume of blood that gets ejected with in particular, it's the left ventricle, but you can just think of it as the amount of blood that gets ejected with each contraction of the heart. And so this is something we've done. I've had to do this in practice where a patient has bradycardia, and we've given them atropine, we've reversed, dexmedetomidine, we've turned them as light as we can. Like, oh, what else can we do? Well, we can put a little needle right here, and I've seen it work. Sometimes it doesn't do anything, but I have seen it work. Okay. So it's a little trick to keep up your sleeve. You're not going to do any harm other than, sticking a needle here, but it can help. Okay, this other little technique that's kind of it's not really acupuncture, but it's kind of related. It's called the vagal maneuver. And people use this when they're stressed out. People who maybe have a fear of flying. So just remember that people will use this to calm themselves down. But so we'll come back to that. So you may recall from anatomy, there's this nerve that runs from your brainstem called the vagus nerve. And this is the longest nerve in your body, right? So it's a single cell that goes all the way from the base of your neck. It goes along your trachea to your heart, down to your stomach, all the way down to your intestines. And it's a very it's a big part of the rest and digest system. So it tells the heart to slow down. It tells the blood vessels. It tells the digestive system to digest. It doesn't really show it here, but it can be influenced by the eyes too. And so what happens is when you stimulate the vagus nerve, you'll make, the main thing is you'll make the heart rate slow down. And the way it's done in patients is we close their eyes and you just kind of gently push. You just kind of gently push on their eyes. So now it's not very often that we have to do that. We don't usually get patients, I mean, tachycardia is not something we worry about too much, but it is something that you can do. The reason I'm telling you about this is because we don't want to do this by mistake. We don't want to stimulate the vagus nerve accidentally, because you will reduce the heart rate. And under anesthesia, your patient often already has a slow heart rate. You don't want to slow it down even more. Well, so how could you accidentally stimulate the vagus nerve? I'll tell you a story. When I was a veterinary student in anatomy, a teacher came by and we were learning about the trachea, and he came by with an endotracheal tube, or he just pretended, and he talked about when he was a veterinarian in practice, he was intubating a dog, and he went in and he came back out and he went in, and he just kept, I don't know why, he just kept kind of fiddling with the endotracheal tube, going in and back out. And what he was doing was by mistake, he was stimulating the vagus nerve. He was trying to just get the tube in just right, but unknown to him, he was stimulating the vagus nerve, and the dog's heart stopped. And so that was his way of, and I think he saved the dog, but that was his way of telling us, when you intubate, don't be overzealous. Just get in there as smoothly as you can, and you're done. I'm not trying to worry you. I think this is pretty rare, but this is why we have you measure ahead of time, and you don't want to try to force a tube that's too big in. You don't want to go in and then be going in and out, because that could stimulate the vagus nerve. Eye surgery, sometimes we have to remove an eye. Sometimes we have to put an eye back in. Something about manipulating the eye will stimulate the vagus nerve. And then finally, the intestines, right? The vagus nerve goes to the intestines. If we start messing, whenever we're handling the intestines, again, we want to be a little careful. And so one, you might be in surgery. Well, one, you intubate. Two, you might be in surgery with me. Or three, you might be the anesthetist for eye surgery or intestinal surgery. And so you might just want to keep in mind that as the veterinarian messes around with that eye, the heart rate could start to go down, and you just need to watch that. You could always give some atropine that would probably prevent any vagal stimulation. Anyway, okay, so we're going to do these little case studies. Now, they're not perfect. I try to make them, kind of as realistic and mind stimulating as possible, but inevitably there's something that I've overlooked. So what I would like to do is we'll take maybe about, so does everyone have those sheets? Were you able to get those off email?
Mm-hmm.
Yeah.
Not yet.
Not yet. Cadence, it's not a big deal, but do you think you can get that in the next minute or two?
Yeah, just give me a second.
Okay. What I'll have you do is you're going to look at case 1, and there's 2 parts. First, I want you have a patient who's they're not staying asleep. They're in a light, kind of a, they're too light. All right, they're not completely wide awake, but they're too light. So I want you to go through this list and you have the same list, and find 8 reasons why, or 8 possible causes about why a patient might not stay asleep. And then part 2 then is then identify all the things you, not all the, well, identify all the things you could do. It's on the next part. Identify all the things you could do to get them back to sleep. And I can always pull up, let me pull up my sheet here. Right, so you're going to see there's the 8 causes, and then there's 10 actions. So I've listed all sorts of actions, but there's only some of these would you use. So you can kind of work together here. I realize you can't scroll down here, but maybe just let's take maybe 10 minutes. We'll see how long you need, and just try to figure out the causes and the actions, okay? And I'm going to step out.
Okay.
All right, I'll step out. I'll come back. I'll come back at 2:50.
Okay.
Okay.
Cadence, do you have your papers yet?
Yes.
Okay, perfect. Okay.
All right, you guys start. In fact,
Right.
I'm gonna get real fancy. You all have your papers?
Yeah.
Well,
Yep.
I can get real fancy and put you in a breakout room, but I'll just let you, that might screw things up. So I'll just step out.
Okay. The first one that jumps out to me, you guys, is vaporizer is empty. I think that's a pretty gosh darn good reason why your patient would be too light or coming out of anesthesia. What do you think?
Yeah, I agree. I think the leaks in the anesthetic machine could also be one.
Mm-hmm. The endotracheal tube being placed in the esophagus is definitely a reason, because they're
The
not getting.
oxygen flow could also be one.
Mhm.
Or
And
the
then-
cuff is not inflated.
Yeah, cuff
sufficiently.
not inflated.
Vaporizer being empty.
Hyperventilating.
Let's see. So far, I have 4. I guess respiratory depression, since they're not inhaling or taking in that gas as efficiently, I guess, as one
Yes.
that, yeah.
Yeah.
So do that one. Oh yeah, definitely if the tube has been placed too deeply.
Yeah,
Yeah.
because that just damages. Okay.
I guess oxygen flow, I don't know if anyone's mentioned it, is inadequate.
I think I mentioned that one a little bit ago, but
Okay.
I don't know. Did we do the leak in the anesthetic machine?
Yeah.
Okay. I have 7 now.
Okay.
Okay.
Wait.
Yeah, so do I.
Yeah. We have, so what we have starting from beginning is we have oxygen flow is inadequate. There are leaks in the anesthetic machine. The endotracheal tube has been placed too deeply. Endotracheal tube cuff is not inflated sufficiently. The endotracheal tube has been placed in the esophagus. The vaporizer is empty, and the patient has respiratory depression.
Yep.
Yeah.
That's 7. Well, excessive use of the flush valve, wouldn't that be kind of like flushing everything out?
Probably.
It sounds like it, yeah.
Yeah.
Because the
'Cause-
flush valve is just pure oxygen, right? So we're just giving, like, we're not
Mhm.
giving.
And don't we use the flush to help? if
No, we
in, like, an
use the flush
emergency?
valve to help them breathe. So
Yeah.
what we do is we kind of build it up. And then no, actually, then that's not the case. If we were using the flush valve, that's the oxygen. That's kind of like expelling the oxygen. Just blood loss. I don't think perfusion has anything to do with them staying super light. What about something as simple as the carbon dioxide absorbent granules need to be changed? Like, I know we have to-
raise the carbon dioxide levels. Not entirely sure about the ISO.
I don't think dehydration or
It says 8, and we found 8.
1, 2, 3, 4, 5, 6. I only have 7.
What was our 8th one?
The flush valve.
that
Oh,
one's eight.
yeah, no, I think we talked ourselves out of that one. That
No.
patient has suffered blood loss. That's perfusion. Patient is dehydrated. Does dehydration have anything to do?
Isn't
I
that the
think
same thing as perfusion? Like,
Yeah, I
being
think-
dehydrated?
Yeah, I think blood loss and dehydration don't have anything to do with it. And I don't think acepromazine. Wait. What does acepromazine have to do with them being light?
Mm,
Don't- Hmm.
I would have to remember what acepromazine does.
It's a tranquilizer.
That can cause.
It's a sedative. It can cause a drop in blood pressure, heart rate.
I mean, if it
If it was
causes,
only, if it received only acepromazine instead of, I'll have to ask him about that one.
Hmm.
Um,
I don't know. I'm thinking it's the flush valve because I thought it was giving pure oxygen. And so we're just like getting rid of the anesthetic. So they wouldn't be getting any, but I don't know. We can try to move to step 2 and
Yeah.
then
Okay.
it'll give us like a hint. I don't know.
Okay. Okay. What are some actions? Choose 10. Okay.
I know the endotracheal tube is one of them.
Yeah, definitely.
Yeah.
I
I don't think we need to give a reversal for somebody that's light.
Don't think so, no.
No.
Increase anesthetic depth.
Absolutely.
Extubate and mask, probably.
No. Check anesthesia machine. Yes.
Mhm.
Yes.
Manually ventilate.
I
Or
don't
if
think the
it's the
breathing for them
respiratory
has anything to
depression.
do with, because the first thing you want to check is the machine and all the connections and all your tubes. You want to check for leaks, that kind of thing.
Mhm.
Oh, administer additional analgesia. Yes.
Additional analgesia?
If it's
Yeah.
the anesthetic machine, we should change it, I guess.
Yeah,
If
if it's our
anesthetic
machine.
machine
Yeah.
help.
Change anesthetic machine.
I think we could manually ventilate because if respiratory depression
Okay.
is a problem, then we would try to get their respiration better.
Mhm. Mhm. Should we be checking oxygen saturation levels on the pulse oximeter?
Mm,
I feel like we're being taught that that's like the last thing we check for after we manually check for vitals.
Mhm.
But you know what? Checking blood pressure on Doppler But and other oscillating devices, I think that's something that's an action we could take to make sure that blood pressure and perfusion is working well.
Yeah.
Oh, so then would that mean that one of the ones at the top involving perfusion would be an answer? Because if
So
we're
the one
fixing-
involving perfusion is patient has suffered blood loss. Well, perfusion is basically oxygen getting all the way through the blood system and getting to the very like ends of the blood system, you know, making sure that oxygen has been traveled with the blood to every single part of the body, because that's also perfusion is also what happens with the isoflurane. It perfuses, you know, into the bloodstream through the lungs.
Yeah.
So maybe not, you're right. Maybe not checking blood pressure.
Well, the way you described it, it made sense. I mean, if you need blood to, you know, make the oxygen travel, then if we have less of it, then it won't travel.
Yeah, true. If you're having a block somewhere, it's clearly the drug's not getting all the way through. So, okay, I'll check it. Check blood pressure, check endotracheal tube, increase anesthetic depth, check anesthesia machine, manually ventilate, change anesthetic machines, administer additional analgesia, push. Oh, and I found didn't he just tell us that you could push gently on a patient's eyes, the vagal maneuver for 1 minute?
Oh yeah, it would make them breathe, or no, their heart would.
Oh, that makes them breathe. Okay, then never mind.
No, not breathe. Sorry, it's their. Wasn't it their heart that starts slowing down?
Yes, it's
Oh.
it increases their blood pressure and creates tachycardia where there would, or not create tachycardia, but it improves bradycardia. So there's 1, 2, 3, 4, 5, 6, 7. Does
Call for
body
help.
does body temperature have anything to do with a light patient? I don't think so.
I don't know.
I'm not sure.
I know it lowers the body.
Pretty sure- From a technician and a student standpoint, I think definitely calling for help is an option.
Yeah,
Dr.
definitely.
Mathis! Maybe extubate and mask, since we are talking about there being like a leak, and you know,
Maybe. Yeah.
that'd be an option. You know, if we're starting first, the first thing we do, if our patient's too light, is we check their vitals and we check our anesthetic machine, oxygen, isoflurane, make sure there's plenty in it, make sure there's no leaks, make sure our tubes placed correctly, make sure the cuff is inflated, even going as far as changing our anesthetic machine. Then, you know, again, we could propose that it's there's a failure of our equipment, and so that we could go from intubating to masking just as an option.
Well, let me
More.
let me show you what I came up with.
Okay.
Now, as I said, though, that you're all saying very smart things, and remember, I gave you a disclaimer. I said this never works perfectly, because you said some things that are quite smart that I'm like, oh, we'll come to that in a moment.
Okay.
So let me pull this up here. All right. Okay, so you see my screen again?
Mm-hmm.
Yes.
Okay, so let me see. Here's what I came up with for the 8. Hold on. Here we go. So I didn't hear what you guys were saying. So here are, I think there's 8. 1, 2, 3, 4, 5. Okay, those are the. Okay, so did your 8 match these 8?
Excessive. Okay, it was excessive use of the flush valve.
Yeah.
That was,
I
we
think
were
just
questioning
missing
that.
one.
Mhm.
Right, the flush valve. When you hit the flush valve, what does it flush into your system?
Pure oxygen.
Oxygen.
Right,
Oxygen.
pure oxygen, 0 isoflurane.
Okay, we were just missing that perspective of it. I think we all knew that, huh, girls?
Yeah.
Right. Next week, just go play around with the machine. It's just pure oxygen, and so whenever you use it, it's going to dilute out or push out all of your isoflurane.
Okay.
What about the other things?
Oh yeah, we got those all right.
Okay, cool. And then these are the actions. And
Mhm.
now, and Raina, what you were saying about blood pressure, you actually might be right, but that's not it was not one of the 10. You're saying like, well, if there's low blood pressure, then there's low perfusion, and so the agent can't get. I'm like,
Yeah,
oh, I'm like, well,
I was saying if there's like a block somewhere or a lack of absorption or perfusion, then you're not going to get all of your meds on.
so you could be right, but we're just going to ignore that, okay?
Okay.
We're not going to worry about blood pressure. Okay.
Which 10 did you get?
So here, they're all bolded now.
Okay.
No, we missed the title again. Title CO2.
Title C.
Extubate mask. Check anesthesia machine. Oh no, we didn't check. Tidal
Oh.
volume.
What does the body temperature have to do, Dr. Mathis?
Yeah.
Oh, I'm sorry. That's not
it? Oh.
That's not, no. Okay. That's not one. So let me get rid of that. That's, that would be for a different problem.
Oh, okay.
So I'm sorry. I think I got kind of carried away there.
Hey girls, we did really good.
We did.
They thought of pretty much almost everything except for checking the end tidal CO2 levels on capnograph.
Yeah.
What
And
does CO2 have to do with anesthetic level, doctor?
well, I was going to say you can use it. Let's just get rid of it. It's just kind of obscure. I'm just going to get rid of that. I mean,
Maybe it could be
yeah,
like if they're not breathing.
I'm just going to get rid of that one. I don't like that one.
But you said it's obscure, which means that there is something factual there.
Well,
as a doctor, what's the first thing you check when your patient's too light?
It's these other ones. So let's focus on these other ones here.
Okay.
Because that's just too. It's not worth spending time on. So let me see in here. We got 1, 2, 3, 4. Okay. So was checking the endotracheal tube, was that one of your, did you guys choose that?
Yeah.
And what are you checking?
Placement and the cuff.
Yeah.
Blocks.
What's that?
Blocks. Something blocking it.
It could be in the wrong place.
Mm-hmm.
And like, it could be in the esophagus. It could be even if you put it too far into the trachea where it's down by the bifurcation of the bronchi, if you're only giving half the lungs isoflurane, your patient's not going to be deep enough. Does that make sense?
Yep.
So that's why you measure
too shallow, too deep, right? It has to kind of be, there's a sweet spot for it to be 100% effective, right?
Yeah. I mean, too shallow could be a problem too, but I'll just say focus on, if you pre-measured it to the thoracic inlet, that should, you just don't want to go too far, and you certainly don't want to be in the esophagus. And then also the cuff. If the cuff is not inflated, well, then a bunch of gas is going to escape and not go into your patient, and then the blockage as well, right? So you probably chose to increase depth.
Yeah.
when I wrote extubate and mask, that would be like, if you have a patient who is like, they are waking up and they are like chewing. I mean, or you think they are about to start chewing on the tube. That would be a case where you might just want to extubate and mask them, right? It's not something you would normally do, but if they're about to wake up, you might do that. You know, you don't want them going through stage 2 excitement while the veterinarian, you know, is trying to deliver puppies from a C-section. You know what I mean? Right. Or like Raina suggested, if they're blocked, if the blockage, you might just extubate them. The machine. Now, one of you mentioned like did one of you mention like what are some things you would check on the machine?
Check to make sure that the ISO is actually full. Check to make sure that you leak tested it. Make sure there's no leaks coming from the machine. Make sure all your hoses are connected properly.
Yeah, all very true. What if your oxygen tank were empty?
Oh, that too.
And that's no bueno.
That's no bueno, right? I mean, one, your patient is not getting oxygen, but they're also not going to stay asleep either. So,
and that kind of led us into our answer of changing anesthetic machines, because I could imagine that being, you know, mid-surgery and having these issues and there being a initial cursory examination and not being able to tell, you know, from your anesthetic machine why your patient's so light. So you just switch it out because it could be anything. And that way you can take a look further.
yeah, absolutely. Right. It kind of, you just, exactly right. Okay. Actually, I made a little, sorry, this is a mistake here. Instead of additional analgesia, I should say, I'm just going to change this to additional
Anesthetic.
yeah, injectable or additional induction agents, you know, propofol or ketamine or, you know, alfaxalone or something like that. So
that's what I've seen a lot on my job sites. Oh, this patient's so light. More propofol.
that's right. So let me, so sorry about that. Let me change that. Okay. Yeah, and of course, you know, and when I say call for help, you know, you don't want to create a panic, but there's nothing wrong with saying, because it's hard to troubleshoot and do anesthesia at the same time. It's like changing the tire on a moving car. So you can always say, hey, can someone come monitor, you know, or do this or that while I, extubate the patient or give more propofol or something like that. It's okay to ask for assistance. Okay. You guys want to take a break or you want to just keep going?
I could keep going.
Okay.
Sure.
You good? Okay. Okay, now so we'll do this. So this may be all we do today. That's okay. So so let's go ahead and do now you have the opposite problem where the patient is excessively deep. So again, same thing, go through and I'm sorry for those mistakes in the other one. Anyway, so go through find 6 causes and then find however many you have in front of you there. 6 causes and 7 actions you could take. All right. And I'll.
Are you leaving?
I'm leaving. Do you want me to leave?
Goodbye. We don't need your looks of disappointment as we brainstorm this.
I'll come back in 10 minutes.
Okay. So ladies, I definitely think that hyperventilating, because then that's for like repeated doses in a quick amount of time, is definitely a cause for being deep. What do you think?
Liver failure, since they can't eliminate it.
Yeah.
Yeah, that could be good.
Yeah, not metabolizing it correctly is definitely an issue. patient is
Babies or
neonatal.
bugs.
I think, I think that possibly patient was neonatal or geriatric. What do you think?
Hmm. I don't know about the neonatal, but
You have to be really careful with anesthesia anyway for a baby.
Yeah, so I think that is one. What do you guys
Mhm.
think?
like it's easy to just go over since they're so like itty bitty, I guess.
Yeah.
Like the-
The wrong dose for a draft horse for a thoroughbred. That could get bad.
So
Oh,
is that it, Cadence?
I
Patient
have
is a
no idea, but it doesn't seem like it'd be good.
appropriate
reduces.
for a
Oh,
thoroughbred or Arabian.
wait a minute. Wouldn't that? But a thoroughbred or Arabian is actually smaller than a draft horse.
Yeah, so wouldn't it be the opposite?
Oh, maybe, yeah.
Although I don't know if they're different in terms of,
Hmm.
yeah, I don't know.
I don't think a leak in the anesthetic machine. Oh, endotracheal tube placed in the esophagus would be a light.
Yeah.
An anesthetic machine would be leaking it, so there you wouldn't be getting the full dose. So that isn't one. Atropine or glycopyrrate. Oh my god, why am I blanking on that right now? Actually, no. Atropine and glycopyrrate would stimulate.
Reversals?
Huh?
Aren't those reversals?
Yeah, I think those are reversals.
You guys are out of calibration.
I think yes.
Yeah.
And patient is hypothermic. I think that would contribute to them being very deep because I see the opposite. They have so in recovery, we had a cat that she was taking forever to recover. But her temperature was so low. She was super hypothermic. Whereas all the other patients who had normal body temperatures recovered in a timely fashion.
Would an overfilled vaporizer do anything?
That's
So
what
no
I
one
was
to a
thinking.
certain
I don't think so because overfilling it, I don't think has anything to do with how much is being vaporized because remember we control how much of
Yeah.
vapor is being administered.
Yeah.
So we're missing one. Huh.
Maybe it is the draft? No, but I don't know.
Draft horse is bigger than a thoroughbred.
Would it be excessive use
But
of the
would they,
flush valve?
but would the thoroughbred metabolize it faster because it's
Because it's
thinner?
like a sport horse.
Yeah.
Oh, well then, yeah. So then you would give more to the thoroughbred. So if you gave it to the draft horse, they would have more on board.
Yeah. That's why
right,
I'm like, I don't know much about horses, but it sounds like thoroughbreds are more sporty than like draft horses. So
Yeah, Cadence is a horse person. I would
I
lean
I
more
don't know a
towards
lot
her.
about them. I just know that thoroughbreds and Arabians are like the thin runners.
yeah.
I concur. I think that the 6 that we've agreed to thus far is patient is hyperventilating, the patient has kidney or liver failure, the patient is neonatal or geriatric, the patient is a draft horse that received doses appropriate for a thoroughbred, vaporizer is out of calibration, and patient is hypothermic. How do you ladies feel about that?
I feel good about it.
Yeah.
There's our 6. So what actions should we take?
We can immediately do the call for help.
Call for help.
That's a definite one.
The first one right there, administer reversal agent.
Yeah. So that way they don't.
What's lower anesthetic? Check vaporizer setting.
Yes.
Take measures to increase body temperature. Would that? Yeah, I think they would help them metabolize it.
I guess change anesthetic machines. I don't know if we would want to change it if they're too deep.
I don't don't think,
Hmm.
I mean, that's optional, but check oxygen now. I don't think we would need an adrenal agonist.
The governor vessel makes them breathe, right?
Yeah, so we don't need to.
So no, not that one.
I definitely do not think that extubating is an option because just in case things go sideways, we do want them intubated,
Yeah.
Hmm.
right? Until they are light enough to be extubated. So definitely while they're deep, we want to keep them intubated.
Yeah.
Um,
Hmm.
oxygen saturation levels.
What about the fluids? Because would that push more stuff out of the blood? But I'm not entirely certain of that.
I'm not sure. And like in the
Hey,
other
what
one, he
else is
said to
the
ignore
reversal
it,
agent do?
but
That's what we did.
He's
for
listening.
How you doing? Can you
we
hear me?
got like 5, I think, on the last one. I think we needed 2 more.
So you're on the actions?
Yeah.
Yeah.
Okay, let's take a look.
Okay.
All right.
I think real fast we should give a anticholinergic just because of the systems that it affects, and it would stimulate, getting the heart rate going and the blood pressure up.
Cholinergic.
Yeah.
Well, let's talk about it. So
Oh,
so
yeah.
your anticholinergics, I wish they would do all that, and I don't know why they don't, but they don't. Your anticholinergics will really just do one thing, and that's they'll raise the heart rate, but it won't increase blood pressure. I don't really know why, but they don't.
Oh, okay.
Yeah, they're I mean, it's important. Raising the heart rate is important when your patient has a heart rate of 20 beats a minute.
Right. But we want to raise everything. If our patient's really super deep, we kind of want to get everything going, right?
Right. And so atropine, the anticholinergics like atropine and glycopyrrolate, they're not going to help. They're only good for one thing during anesthesia, and that's to raise heart rate.
Mm-hmm.
Yeah. Okay.
We did have two questions, but do you want to go over this with us and then we'll ask?
Sure. Let me
Okay.
let's see what happens if I can get this thing going here. Okay, so there's your patient there. All right, hold on. Okay, so these were the 6, 1, 2, 3. So those were the 6 causes that I came up with.
Really?
Yeah.
Okay.
So overflow
Okay,
vaporizer.
So the reason that I talked these ladies out of that as an option was because in my mind, however much you have in the vaporizer doesn't matter because we control how much is coming out of the vaporizer with the knob setting. So even if it's overfilled, we still control what comes out 1, 2, 3. So that's why I talked them out of that as an option.
Well, let me because as I'm going through this, this kind of forces us to look back like 5 weeks ago. So I have to admit I've used a few different books when I teach this course, and then there's certain things I'm like, oh, I don't think we actually talked about that. So but I think maybe that's why I put this in here. Okay, well, look at this. Okay, so we didn't talk about it in class, but here's McCurnin, and maybe I'll see. Hold on. Okay, I'm just gonna hold this up to the screen here. So this is your book, and can you read that?
No, because you're little.
Really new.
Wait, I can switch you. Hold on. Hmm.
Mm.
Are you able to see it?
There it is. The level of liquid anesthetic in the vaporizer should be noted before each procedure. To function properly, it must be between the upper and lower lines of the window. Refill is needed, but keep the vaporizer at least 1/2 full at all times. Overfilling a vaporizer will result in anesthetic overdose. Underfilling will lead to an inability to keep the patient anesthetized. Okay.
So overfilling, I guess it can spill into parts that it shouldn't belong, that doesn't belong.
Mm.
Okay.
And there might have been, I don't know, there might have been some workbook questions about that. I don't know. But that's, you know, it's, they have it highlighted here. So that's, but I mean, I think we never discussed it, but it was in the reading.
Okay.
But I don't, you know, it's okay if you didn't know that. That's kind of why, I think that's why I included it here, just because all those technician notes are highly important in the book. So, but if you're like me, you tend to not read them. Even though they're actually the most important part of the book. Okay. Anyway, what about the other things? Do you agree? Do you want to talk about?
Yeah, I think we got the other one.
That's what we got.
Okay. So it was just the vaporizer.
Yeah.
Yeah, thank goodness Cadence is here, because we were like, oh, it's got, draft. Originally we were like, oh, draft horses are so much bigger than, thoroughbreds or Arabians. How can you give them more? And then Cadence pointed out, no, the metabolism of a thoroughbred or Arabian, because they're pure muscle racing machines. So you would give a higher amount to them because they metabolize and they go through it faster. So if you were to give a draft horse who has a slower metabolism the same dose as a race horse, you could actually make them too deeper or overdose.
Yeah. And I don't know the reason why. Maybe it's because of their metabolism. I mean, draft horses are plenty muscular, but there's something, they have, but it's kind of it's a different kind of strength. Anyway, so yeah, I don't know the reason why, but that works. Okay. So then the actions, here's what I came up with as for your seven actions. So certainly you could administer a reversal agent. That might help. What if you gave dexmedetomidine, what is the name of the reversal agent?
Atropine.
Atropine's not a reversal agent.
Oh wait, no, it's not. Wait.
It sounds a little bit like atropine.
It does sound like it was.
It's the what is it? Mazole, apamazole?
Yeah, atapamazole.
Yeah, that.
There it is. Pamazole.
Atapla. Atapla.
It was like something with I and
Yeah.
Zole.
Atapla. What about an opioid? What could you do to reverse morphine or
Naloxone.
naloxone? Right. And those are really the main two you would see. You could lower the anesthetic depth. What would be the quickest way? It might be too quick, but what would be the quickest way to lower the anesthetic depth? We talked about it in the flush valve.
Mm-hmm.
You could certainly do short bursts.
Mm-hmm.
Don't just hit it, but you can probably use your flush valve here. Checking the vaporizer. Sometimes we turn up the vaporizer, because they're getting light, and then we forget.
Mm-hmm.
We say, okay, we're going to turn that down in 2 minutes, and we forget to turn it down. Changing machines. Now, here's a case where you might want to increase body temperature because as your patients get hypothermic, they get more sensitive to the drugs. The MAC you know, of isoflurane actually goes up. Wait, no, goes down as your patients become colder and colder, right? They take longer to wake up from anesthesia too.
You know, I used our little tortie from Wednesday as an example and said, you know, of all 4 patients, that tortie was the longest to recover because she had the lowest temperature. And that how we reversed that in recovery was we got her warm.
Right. And we learned a cool trick from Natasha to blow in their face. I thought that was really cool.
Yeah. How do you get them to swallow? You blow on them.
To blow on their face. That's so cool. And then IV fluids, you know, it's dilution is the solution to pollution, right?
Okay.
So IV fluids just kind of helps to wash things out of them.
Yeah, Vanessa said that was a good one.
Yes. And then of course, again, you can always say, hey, could someone help me? I gotta give this atipamezole and I'm going to change machines and someone bring me some warmies or, oh gosh, I forgot to, whatever. So,
should we make sure our fluids are warm because we don't want to make them colder, right? So if we want to give a nice bolus of fluid, shouldn't we warm them up?
Well, but it's always going to run through that fluid warmer. But I mean, you're right. The bolus is not going to get that warm.
I've actually never, in the 5 practices I've worked at, our school is the only place I've ever seen use a fluid warmer.
Me too. That's why
I've actually seen some techs actually get real MacGyvery and use like a warm bowl of water and just drape the line in there. And it would probably be for this situation, you think?
That would be very appropriate.
Okay.
That might help solve the problem. Maybe you get a big bowl of warm water and drape a whole bunch of because our little fluid warmer is not going to warm up a bolus. But frankly, I'm not sure you can when you're giving fluids really fast. I'm not sure there is a way to warm it up. But I mean, you could microwave the whole bag, I suppose. Anyway, yes, good point. Okay, we're doing all right here.
Yep, and Cadence pointed out that one of the main things we should do is call for help.
Call for help, yeah. I think this is, you guys, this seems, I think we might as well, this will kind of be all we'll do today are these 4 cases, and then we'll, I think that's okay.
Okay.
Yeah, so, I'm gonna step out again. So now you got case 3, a patient that's either not breathing or breathing kind of slowly.
Okay.
Okay. I think, yes. And there's only 3 causes here.
But 9 actions.
Right.
Okay.
Sorry, okay, I think we're good. Okay. I'm gonna step out.
Fine.
I'm leaving.
Okay. What is the 4th one?
There's only 3.
No, the 4th option. My page when I printed it out cut it off.
Oh.
These opioids are propofol.
Yeah, I think that's definitely an option.
Yes.
I know that the patient's anesthetic depth is excessive is an option. Do you concur?
Mm-hmm.
Then what's the 3rd one?
Would it be the cuff? Or would it be?
I think so, because then that means the oxygen is not going, it's not staying in, maybe. So they're not breathing properly.
But they can't they breathe around it?
Yeah, they probably breathe around it.
The tube. Oh. Maybe the carbon dioxide granules. Because it'll cause the, what is it?
They're
Hypercarbia.
feeling more CO2.
I forget. There's only 3.
Mhm.
Hmm.
Well, I don't think it's hyperventilating.
No. Hmm.
I think it might be the granules, because if they're getting in too much carbon dioxide, then it's gonna make them breathe less. No, or is it the other way around?
If you breathe when you take in, when you want to get out carbon dioxide, it's if there's an
So if they have too much carbon dioxide in them, would they breathe
I think they breathe
like
more.
more? Mm. Okay, so then
Hmm.
Hmm. It, I think it's the hyperthermia.
is making them breathe.
Yeah,
slowly?
is making them breathe slowly because it does cause hypoxic apnea.
True.
So you think it's hyperthermic? And
Would having a fever, what is, okay, I'm looking at hyperthermia. I'm looking at hyperthermia. What are the,
I guess when I think of having a fever, I think of someone breathing more because they're trying to, what do you call it? Like get rid of that heat. Kind of like when you're working out,
right.
but I don't know.
Isn't propofol cause respiratory depression?
Russ,
Oh yeah,
what?
we clicked on that one. Never mind.
Yeah, we're
It's like I forgot. I saw it. I've missed my little mark by it.
You know,
What does?
yeah, I'm not sure about the third one. Yo,
Do you remember what atropine and whatever the how do you pronounce that word? I can't pronounce it right now. Does?
like a pyrrolate, they're the ones that stimulate. I can never
is
say
it
it
the
right.
heart? Or...
Yeah, they're the ones that vasoconstrict. They're the ones that cause your body to go into fight or flight. Is that the parasympathetic nervous system? I can never get it straight in my
sympathetic?
head.
I think
Uh-huh.
sympathetic.
The sympathetic nervous system, the one that puts you in fight or flight, the
Yeah.
one that gets your heart rate going, that's atropine and glycopyrrolate.
Okay.
So it probably wouldn't be that one then.
No.
I don't know about acepromazine.
Acepromazine. Didn't we talk
That
about,
causes
isn't acepromazine
vasodilation.
a tranquilizer sedative?
Well, if it's a sedative, then we would expect them to breathe less or slower, I guess, since they're calming down. But I don't know.
Yeah, but it's not as depressive as like propofol. Propofol causes apnea and respiratory depression, point blank.
We can start picking the 9 actions, I guess.
Yeah, let's go to actions. Let's make him tell us. Why do we have to work this hard?
Okay.
Right? All right. So what are some actions that we could take? Ladies, would you administer a reversal agent?
For like opioids or propofol?
Yeah.
Lower the anesthetic depth.
Absolutely. Check anesthesia machine.
Yep.
Hold on a second. Look right there. Manually ventilate. Be prepared to tell us.
You would ventilate.
I'm walking back in.
Manually ventilate.
Annually ventil. Did I say something? What?
No.
Do you guys need more time? Are you kind of ready?
We took longer on this one.
Do you want more time?
Mm,
No, why don't you go ahead and go over it with us?
We'll go over. Okay. So so here's what I came up with for the three reasons.
Oh, okay.
hyperventilating?
Explain to us about hyperventilating, doctor, please.
So
Yeah.
that's that post-induction apnea.
Oh, because
okay.
when we hear, because post-induction apnea, you say post-induction apnea, and we hear, oh, you get induced and you stop breathing. Whereas we see the word hyperventilating and we're thinking lots of breaths.
Well, but it says patient was hyperventilating, right?
Oh.
Now they're not breathing, or they have a really low respiratory rate,
Okay.
right?
Okay.
So if they were hyperventilating while passing through stage 2, that's what causes post-induction apnea.
Okay. Well, those are tricky words. Tricky words was. Okay.
Well,
But we got the other two.
okay. Okay, then you got the opioids and you got the excessive death.
Mhm.
Yep.
Okay. Now let's look at these are some of the actions. So so let's look at this.
Oh, check ET2. Yes.
Again, and these aren't perfect. So again, and this gets a little, you start to see things over and over again. So again, maybe your patient is excessively deep, just like the last patient, right? So you could reverse the opioids. I mean, right? You all told me how opioids can cause respiratory depression, right?
Mhm.
You could
Mhm.
reverse that. You could check the tube, make sure it's not, it's not plugged, right? Lower the depth again, using the flush valve, checking the machine. Really, you're kind of checking the same things we talked about before,
Mhm.
right?
I have questions.
Yes.
Hold on. So my question is, why would we check CO2 levels for a patient that's not breathing? Because there wouldn't be any. And why would we check oxygen saturation levels on a pulse ox? Because you always tell us that the last thing we want to do is use our machines.
Well, no, I don't say the last thing you want to do. But I say it's something you need to be aware that the machines can be inaccurate,
Like not rely on them.
right? And it may not be the first thing that you do, but it certainly is something you can do.
Okay.
And so to answer your question, Raina, you're right. If the patient is just not breathing, well, you're right. The capnography is not going to tell you anything. But remember, this patient, I said, it could either be not breathing or could have a really low respiratory rate. So let's assume this is a patient with a really low respiratory rate. What will the capnography?
What's the capnographer going to tell us about the depressed
Right.
respiratory rate?
So here's a patient. The patient's only taking like 1 breath a minute, and you look at your capnographer, and the end tidal CO2 levels are really low. What does that tell you?
They're
That
not.
there isn't a lot of carbon dioxide getting out.
That's right. Well, it's telling you no. It's getting out fine. It's just telling you there's just not much there, right? So there's just not much carbon dioxide that needs to leave, right? Your patient exhales, and there's just a little bit of carbon dioxide in their breath. So what does that tell you?
They're not breathing as much. Or
It's not that. When would you see that? When would you see a patient with a really low end tidal CO2? Well, in fact, let me start over. Same Same question, but let's say here's a patient, they're only taking 1 or 2 breaths a minute, and you look and your end tidal CO2 levels are higher than usual, right? They're supposed to be 40 to 55. Well, they're 65. Okay, let's answer that first. So you said the correct answer, Vanessa.
For that one.
For that, well, for that one. So what does that mean? If your patient exhales and their end tidal CO2 is really high, what does that tell you?
So they're not breathing.
They're not breathing enough, right? They're not breathing enough, and they're not getting rid of that carbon dioxide. So when they do exhale, I mean, there's really a lot more than there should be.
Okay.
Right? And so that patient, you could manually ventilate for them, right? You could just give them 8 to 12 breaths a minute. And what should happen as you do that? What should happen to your end tidal CO2?
Start to lower?
It'll start to lower, right? It'll lower, because you're helping them get rid of carbon dioxide. Does all that make sense so far?
Yep.
Raina and Cadence, does that make sense?
Yes.
Okay. Now, totally different situation. Now you have a patient, they're taking 1 breath a minute, but their end tidal CO2 levels are very low. That's what you'll see with this patient, the patient who is hyperventilating while passing through stage 2. Okay, then you get them under anesthesia. They just spent 60 seconds hyperventilating. Is that patient going to have any carbon dioxide in them?
No.
No. I'm a little lightheaded. Sorry,
Ministers oxygen to Dr. Mathis.
just give me a minute for my carbon dioxide levels to come back up. Okay, I'm back. That's what really happens. So that patient, do you want to give them 8 to 12 breaths a minute?
No.
No. If you give them 8 to 12 breaths a minute, are their carbon dioxide levels ever going to come back up again?
No.
No. Is that going to harm the patient? No. Is it going to be a pain in the butt for you?
Yes.
Yes, you're going to spend the next 30 minutes breathing for them. Right? So those are the patients that have post-induction apnea, and you don't want it. You just want to, you're going to watch the capnographer, and you should see the levels rise, and you're only going to give them like 2 to 4 breaths a minute.
Okay.
That makes sense?
Yep.
I've never worked at a place that had capnography, and it's very stressful when the patient's not breathing. You're like, well, why? The capnographer will tell you why they're not breathing. Well, it can help tell you why. If you don't have it though, you don't know. You don't know if it's post-induction apnea or not. Okay, and then checking the oxygen saturation. It's helpful. It's helpful to know. It's the best thing that we have for oxygen levels. Well, it's not the best thing we have. What's the best thing that we have? We don't have it. What'd you say, Vanessa?
Never mind. I said ourselves, but.
Well, ourselves, but for equipment, if you worked at an emergency clinic, for example, they might have it.
The blood gas.
Yes, blood gas. That's where you get a little arterial sample, and then you have to really quickly process it. But that gives you an exact reading for oxygen. But we don't have that. Most places do not have that. So the pulse oximeter is nice, Okay, and then this is where you could take your big scary needle and poke your patient at the That's a little philtrum here. Because that might make them take a breath. All right, we're good?
Yeah.
Yes.
All right, here's our final case. Remember, the patient might be hypotensive. All you know is that if it's a small animal, you know, their mean arterial pressure is less than 60, or if you want to pretend that the patient is a horse, the mean arterial pressure is less than 70.
My
So,
screen went black.
what's that?
My screen went black this entire time. It was perfectly fine. Now it's
Oh,
black.
well, you've got the email, right?
Yeah.
So it says the same thing. Okay, so I'm stepping out. So they've got 6 possible causes, and I don't remember the actions, but this will be our last little thing here. So take like about 10 minutes, and then we'll wrap things up.
Okay. All right. So hypotensive means low blood pressure, right? Would
Better
blood loss be one? What was that, Cadence?
I have to re-pull up the email because my computer screen's black, but I can still hear you guys.
Oh, okay.
Just give me a second while I pull it up on my phone.
Okay.
You guys can still talk.
Reina, would you agree blood loss? Oh, Reina may be gone.
Oh. Hang on, I'm just opening it now. I'll be there in a second. Okay. Case 4. Okay, I'm here. Hypotensive.
Okay.
Yeah,
So
blood loss,
hypotensive is low blood pressure.
Yeah,
So blood loss, I think, could definitely be one.
blood loss,
Cardiovascular disease.
equipment error,
Yes.
dehydration. No. Yes. Did dehydration cause it? Maybe.
Dehydration?
Yeah.
Oh, is that? Oh, I see it now. It was on the next page. Dehydration.
Promising causes hypertension.
Would it cause? I'm trying to remember.
Yeah, 1, 2, 3. I'm just doing 2 more.
I don't think it's the ET tube.
No.
I was talking. So do you think a benzodiazepine would cause hypotensive symptoms?
Maybe.
Maybe. Why do you think it's the benzo?
Because it's not atropine and glycopyrrolate, because those are vasoconstriction. Hypotension is characterized by vasodilation.
Acetylcholine is a vasodilator.
Yeah, what?
Isn't acetylcholine a vasodilator? Was it a vasodilator?
I don't remember. You're saying for ACE though, right? Not atropine.
Yeah.
I mean, maybe. Because all the other ones don't really make sense.
I don't know how an endotracheal tube could cause hypotension. Blah, blah, blah. I can't talk today.
So maybe acepromazine and the benzo?
Mm-hmm.
Maybe. So I think we got them all. We got the blood loss, cardiovascular disease, acepromazine, benzodiazepine, or dehydrated.
And
Yeah.
equipment error.
Yeah, and equipment error.
All right.
Okay.
Okay, actions. Reposition cuffs?
okay.
Absolutely.
Yes.
Clear.
IV fluids would be one.
Yep.
Call for help, definitely.
It's above, one above. He doesn't have it on there. What's the option after lower anesthetic depth?
Check end tidal CO2 levels on capnographer.
Would we
know
need
if
to do that?
I don't know how that's related to hypotension.
Oh, I think lowering anesthetic depth.
Would the vagal maneuver do anything? I can't remember. Was it lower and strengthen the heart? Or would
yeah.
it be,
We would want.
or would it be the stimulate the acupuncture point?
The governor one is the breathing one.
I think you also said it
And
does
the
the heart.
I think the vagal one is the heart. Because the governor one is the one on the nose.
Yeah, but didn't he say it also stimulates the heart to beat?
Oh wait, yeah, I think you're right.
Like,
Yeah.
the cheese was cold and hard to melt. Thank you.
So I think it's also governor then?
Yeah. Because the one with the
You think
eye
so? You think
lowers
it's the
heart rate.
GV vessel?
I think I do remember him saying that. It stimulates to
Because,
breathe
the
and
governor vessel was the one that stimulated the heart to beat stronger and to breathe. And then the one with the vagal maneuver with the eyes was the one that lowered the heart rate.
yeah, I think you're right, Cadence.
So we're opting for the GV 26.
Yeah.
Okay.
So that makes 4. So we
I
would
think manually ventilate,
Hmm.
checking oxygen saturation levels.
for our hypotension?
Yes. Because why is an oxygen saturation level an issue? It's a perfusion. What helps perfuse our blood pressure?
Yeah.
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 So
I say that one too then. Yeah.
That makes
about
5,
all.
I think.
Yeah, that makes 5.
You said 5 or so.
Yeah. Sounds 5.
give me an example of an anticholinergic.
Oh
Given.
dear. Drug names are my enemy. What are you?
Are we saying an anticholinergic is also an option?
No, I just need to remember what it does.
Oh.
Didn't he say it only stimulated one thing? We wanted to do several.
I'd have to look at my notes.
I'm back.
I think anticholinergic is right. And the acetylcholine has to do with blood pressure.
Okay.
Oh,
Let's see if we're right, since he's back.
You're not talking about using anticholinergics for blood pressure, are you?
No, why would we?
Because I just told you 20 minutes ago that they are useless for blood pressure.
Oh my gosh.
They only raise heart rate.
Oh, that's right.
They did one thing. So remember what that one thing was.
I wish they raise. I don't know why they don't, but they don't. They just raise heart rate. Okay, so you guys ready?
Yes.
All right. All right. So these are like possible causes, right?
Let's see.
Good.
Yeah, I think we got all of them.
Got those? Okay.
Oh wait, no,
Mm-mm.
no, we put
No, we put benzo.
instead of isoflurane and SIBO.
Gotcha.
Uh,
Right.
Mm.
Of all the drugs you've studied, the benzodiazepines, they're probably the safest.
Oh,
Hmm.
So
Okay.
what's a benzodiazepine that you have used?
Mm, that we've used?
Yeah, you used it. Sorry, hold on. You used it the first 4 anesthesias.
Okay.
is it the Dex?
It's not the Dex.
What did we use in the first?
Well, what do you use? Yeah, what did you use your first anesthesia? You used ketamine and
Midazolam?
midazolam.
There we go.
Midazolam is a benzodiazepine. So is diazepam, right? That Valium. Um, so those are the 2 most common. There's a drug called telazol,
Mm-hmm.
which has toletamine and zolazepam. And zolazepam is a benzodiazepine. So anyway, so those are really they have the least the least negative effects. What I mean is they don't affect blood pressure or heart rate or respiratory rate. They're really safe drugs.
Mhm.
We give diazepam or we could give midazolam to a patient that's having a seizure, right? It'll stop the seizure. We use a different one for patients that have firework or storm phobias. Oh, we just lost Cadence.
No.
But have you heard of Xanax before?
Mhm.
It's Xanax. Xanax. That's alprazolam. But anyway, so there's lots of them. They show up in a lot of different parts of medicine. Um, um, but they're really safe. They're patients with heart failure or liver failure, whatever. Well, maybe not liver failure, but certainly heart failure. Um, they'd be okay to use.
Okay.
Okay. Um, now they don't do much. They're really just a sedative and muscle relaxation. They won't put a patient under anesthesia, right? You could give as much Valium as you want. You'll never be able to intubate a patient. Does
Mhm.
that, do you follow me?
Mm-hmm.
Yeah, it's just a sedative. It's not an induction agent. But we use it with ketamine. You could use it with propofol. I mean, you could do all that. Let me just make sure my office hours start in a minute. Let me just make sure. Oh,
Okay.
that was Cadence. Okay. Um, but anyway, so you can use it with induction agents, but just remember it by itself, it will never put a patient under anesthesia. Okay. But blood loss, dehydration, right? If you have less fluid in you, your blood pressure will suffer. Okay, so let's look at some of the actions you could take. I think I said, I'm not sure. Anyway, here it says 5, and then here it says 6.
Uh-huh.
2, 3.
Oh, we didn't put lower anesthetic. Here we go. Oh, an adrenergic agonist.
So you might recall when you learned about equine anesthesia,
Mhm.
we talked a little bit about dobutamine, and you watched a video. It was a British guy talking about a horse, and he said, like, and we have some dobutamine that we could give to raise the horse's blood pressure. And you're going to learn more about those on Wednesday because they play a role in post arrest care.
Mhm.
So after CPR, we sometimes can use those agents. But you can use them during anesthesia. I mean, but most places don't have dobutamine, but it's kind of cool if they do.
Mm.
Okay. And then fluids, of course, especially if your patient, well, for any patient, but giving fluids, right? You add more fluid to their circulatory system, and then that's a nice way to raise blood pressure.
Mhm.
What was it you said? Something diluted. What?
Well, that's different. That's for
For depth.
that's if that was I said dilution is the solution to pollution. That's how fluids can help when you've got when your patient is excessively deep. But here you're using it not you're not diluting. There's no pollution that needs dilution. Here you're just adding fluid to the circulatory system, and then that will, by adding fluid, just you're going to get, blood pressure will increase.
Mm.
It's like the opposite of dehydration or the opposite of blood loss.
Mhm.
All right.
Mm-hmm.
Okay.
Well, that's fine. We'll stop there.
Okay.
That's totally fine. Okay. Well, nice job, and I think your classmates will appreciate getting to watch your very, very smart, logical approach here. And I think we learned a few things too. So any questions?
Mm.
No.
Okay. Well, then we will.
If you didn't want to go over. No. Yeah, that's it.
That's right. There's more in the book, but I'm not. We could spend several weeks just talking about each. The book explains other things very well. I just thought I would pick 4 very common ones. And then and on Wednesday you will learn how to do CPR.
Cool.
Okay.
Hey, one quick question about CPR. I was told that on no uncertain terms, even though it's our natural inclination, if we see an animal arresting and we want to start CPR, that we are not allowed to touch the animal unless the doctor says so.
No.
No, I'm right. You're not allowed to touch them unless the doctor, or no, I'm wrong.
I would say no, you're wrong.
Okay.
Because it'd be better if it was, a veterinary technician.
Mhm.
But you want someone with, but you need, if a patient has arrested,
Mhm.
you need to know now if they've arrested. You don't want to be like, oh, okay, go and get so and so to check. It's like, no, you check now, and if in doubt, start CPR. CPR is not going to hurt a patient.
Right. I was in a position as an assistant where a patient had come in with a blockage. The owner did not want to do a pre-anesthetic blood work. We gave the anesthetic, the patient coded. My instinct was to get in there and start compressions. And the veterinarian was like, no, stop. And then I got admonished because I was told that it wasn't my place to even assume that CPR was given. And the veterinarian was very upset because she was like, oh, the animal died because it had an adverse reaction to the anesthetic and we didn't need to attempt to resuscitate it. And I actually got written up because because I started CPR without permission from the doctor.
Well, I don't know all from what you're telling me, here's what we're going to talk about next Wednesday. What we're going to say next Wednesday is someone is going to run the code, right? Someone is going to lead the effort. That person, who is that person going to be? It's the person with the most experience. So that person could be the veterinarian. It could be the veterinary
Oh.
technician.
Okay. I was just told I was in trouble for doing it at all. And my understanding was because, you know, it was just a natural consequence of the animal's adverse reaction. And so I didn't realize that there was like a hierarchy in the situation.
Well, have you been trained to do CPR in animals?
Yes.
Where was that?
A 49er ROP.
Okay. Well, let's talk more about this because again, I don't know all the, you know, I'm only hearing your side of the story.
Yeah.
But in general, if an animal arrests, you should do CPR.
Okay.
Mm.
I've also heard that you need the owner's consent.
Well,
For
just as I said that, I'm like, well, I should stop and be like, well, you do. I mean, here's what we do in practice. If an animal arrests, we start CPR. We start basic life support. So that's chest compressions, um, um, you know, we can intubate, and we can breathe for them. So we start basic life support, and then we go and we, you know, we can do that for several minutes, and then we get the owner's permission.
Okay.
Okay.
That's good to know. You know, letting you, as soon as we graduate and you let us out into the world, we need to know this.
I mean, you know, I've only, you know, in 20 years, I've only been around a couple of patients that arrested, but I remember the first one, I never got trained in CPR, and you know, but luckily, Jessica, the technician, she used to work at an emergency clinic. So, you know, she and I kind of looked at each other and, you know, she knew, you know, I can't remember what we said, but she knew that she needed to run the code. And so she's like, okay, you start, you know, give 120 compressions a minute. You know, get this ambu bag on them, and I want you to breathe for them, you know, one breath every 6 seconds. You know, you get the clients, you know, you need to tell them that their pet is arrested. You know, we you know, would they like us to do everything we can to try to save them? You know, and I think she even had to say, like, you know, it's, you know, so you get the nicest receptionist or whoever has the best people skills, because that's a very emotional conversation to have. And then meanwhile, and then the client says, yes, do whatever you need to do. And by the way, you may want to ask the owner to make like a $300 deposit or something like that. And then meanwhile, then Jessica's like, okay, you place a catheter, you know, you know, get the fluid set up, you give epinephrine, give atropine, you hook up the ECG. You know, she's just kind of, she knew what to tell people to do. So Raina, I don't know, but it might just be that they're like, well, so I'm sure you got great training through ROP, but again, I don't know. You know, maybe you knew more than they did. I don't know, and maybe that kind of ruffled their feathers.
Not one bit. No.
What's that?
I did not know more than the doctor.
Well, no, I just mean as far as running the code. But it may, you know, it sounds like you were trying to do the right thing. It may have seemed unusual to them.
I think it was an unusual situation.
Yes.
But being a veterinary assistant and not a technician or a veterinarian, or following the case from the gate, I had very little information. I just knew that my instinct kicked in, and I saw, something stop breathing. I did the same thing last Christmas. A man started choking at a work Christmas party we were at, and I freaking cleared his throat and I gave him CPR. It's just hard for me to see things stop breathing.
Right. I mean, I think I would probably just say my plan for you for the next few years would be probably let someone with just more work experience lead the way.
Okay.
Because you're going to see that there's basic life support and there's advanced life support, and you usually need both. You usually have to proceed to advanced life support, and probably the person who's been out for 3, 4, 5, 6 years or more would probably be the right person for that.
Right.
But you might be at a place where it's just you, and I mean, it might be you. So, hey folks, I got to get into my office hours, which is
Okay.
a different Zoom. So, you can join me there if you want to keep talking.
Nope, I have another appointment. Thank you.
Okay. All right. Thanks again for coming. Hi, Sam. Are you here to tell me to get to my office hours?
No, I just wanted to see if you were still going, but if not, I was just like trying to hop in if you still had it going. If not, you're fine.
That's all right. No, I understand you're tutoring during these hours, so sorry.
All right, have a good day.
All right, Sam. All right, Vanessa. Thank you all.